So we're here doing another demonstration to speak about the concept of contact as control and control as safety. So we're subdividing some of these and showing it in different positions. Now, it's tough to see. The end of the table's right over here, so it's not a perfect shot, but we're going to work on it. Now, as far as contact is control and control is safety, we've also talked about patient positioning. We've talked about negative space being a problem. Right? So the space between the edge of the table and the patient, in this case, is about the length of my hand, and I can just measure that by putting my hand down there. Now, I can't absolutely control that depending on the width of my table, but I can I slide backwards just a little bit? Okay? Now, the challenge here is that his knees were already at the edge, so I brought him closer to me, but now his calves are on the edge of the table, so that's not the most comfortable. He's a little bit less likely to relax. Slide forward just a bit. Okay. Now, I want contact, so I can either bring him to me, but in this case I can't bring him all that much closer to me, so I can get closer to him. Okay. Now, the other trouble that I'm going to have, so if I'm working in the coronal plane, this is completely fine. So we've talked about contact and control. I'm going to get close to him. I'm going to put as much of my body on him as possible. Now, I'm not going to use just my hand on his shoulder to create motion. I'm going to drape my arm across him, right? So I go in front of his shoulder with my elbow. I come across his whole shoulder girdle, and I even reach across as far as I can go. So now, just with this arm, right, I can do a lot. I add in my body for stability, and I can take him wherever we need to go. Now, something that would be intelligent of me, if I wanted to rotate him, okay, so give yourself a hug. Now, if I want to rotate him, I can go ahead and I can do it up like this, right? So you'll see people practitioners who will work like this. You see all the space between he and I, right? Now I can grab him and I can rotate him as far as he can go. Now if he can go farther, my problem is that, especially if I stay tight to him, is that I will run into the table. So something that I can easily do. So I'm just going to have you slide down here, so sit right there. So we'll get a little closer to the camera here. Now give yourself a hug. So now I'm going to turn my back to the table, or to the camera, but you can see as I can walk around the table, I can take him farther. So it's entirely possible that depending on where my patient is on the table, that if I try to create that rotation, with or without contact, good contact, I can end up running out of some of it because of the table. So that proximity, that removal of negative space, so less table means I need to make the patient more stable, or the space between us is unstable, so talking about negative space. Now, we also want to talk about controlling multiple things. So, or the idea of broad contact as diagnostic. So I could go ahead and push into things, or I could side bend and I can check each vertebral level, or I can create broad contact in a region. And as I create that side bending, now this is patient passive, I can identify with this broad contact where the problem is. Now, the problem happens to be higher, so I would identify that, I would work with that. And I can repeat the process anywhere. Some people prefer a thumb bar, right? So then the whole heel of my hand becomes diagnostic, or I can just put my hand like this. Either way, I get a broad piece of information. Now, if I was trying to work with the patient's arm, okay, working with the patient's arm from here, so I can work with this arm, the problem is that it's pretty far away from me. To get to the wrist, I have to reach pretty far, so effort and load are far away in this case. So I can approximate that, I can do a pretty good job here. You might not see it, but what I can do is essentially match my arm to his, the best of my ability. So I walk in, I match up to him, and then I can have good control. So my arm is essentially under his arm, matching his arm. I can control him. Now, one of the challenges I have, if I want to palpate here, palpate through the shoulder or through any other area, is that I could start moving the patient around, moving him off axis. I can stabilize him with my body, so that gives me a chance to work on the shoulder girdle and other things. Conversely, what I can do is I can use the edge of the table, right, get him close to the edge on the side or on the arm that I want to work on, and I can come over here and I can begin to work on this arm, right? So I can test it better. I can get close to this arm. I can check the elbow. I can check the soft tissues. I can check the hand, right? Now this is difficult to do, okay? Move to the middle of the table. This becomes suddenly more difficult for me to do. Now I can do it by getting close to him again. I can do all of these things, right? But it becomes much more useful to move him to the end of the table so I can actually get even closer to his body to control him for some things. So come back over here. So sometimes, depending on what we're trying to display or what we're trying to work on as practitioners, we will move the patient around the table so that we can gain advantage. So now, I can get in tight to him as well. So if there's some reason I wanted to work, say through the rotator cuff or through, through the lat or whatever I wanted to work through, I can get much closer to it and I can keep him more stable. I can control him better. So you see this contact here. I can broadly contact to stabilize and to help him. So these ideas of really wrapping around patients, really coming into contact with them with as much surface as you can reasonably and respectfully come into contact with them. It will help you to stabilize them, to control them, to create multi-point discrimination. So the more of him that I can touch at one time, the more I can understand where there's motion loss. It works better for both of us. So again, those concepts that contact is control, control is safety. As far as palpation, get as much as you can touch. As far as patient positioning, less stable means I need to make the patient more stable. Space between us is unstable. And it all leads back to broad contact, and we really want to make sure that we use that as best as we're able, because it allows us to assess and treat more essentially in more of an integrated or fashion, or more at the same time, or in a smoother fashion. Many ways to describe it, but the idea is I can transition between one and the other. So the second I have more information as far as palpation is concerned, I can identify in a more accurate way where that motion loss is, and the key to it being contact and control. Right? So I really use as much of my body to get in contact with as much of the patient's body as possible.